So today I'm going to be talking about, obviously, prescription drug use in Appalachia and how we've come about to the epidemic that we're currently in. I don't think anyone in the audience would argue that we are indeed in the midst of a prescription drug epidemic. Here we're looking at the number of new users of non-medical prescription pain relievers, and opioids in particular, in the last 30 years, and you see a meteoric rise. Well, this is not coincidental. In the mid to late 1990s, some recommendations came down that pain be recognized as the fifth vital sign. And as such, when you are recognizing pain, you also have to treat pain. So if we actually map sales of prescription opioids on top of this, we'll see a very similar trend. The last figure went to about the year 2000, and I wanted to see whether these trends were continuing, because obviously 2000 was really just the beginning of the prescription drug epidemic. And we see that the numbers continue to rise. These are new users. And we see that although they rose until about 2002, 2003, they're actually been steady in the past few years. And actually in 2011, that data was just recently released from the National Survey on Drug Use and Health. We actually saw a decline. Whether this is a sustained decline, we don't know. We'll need several more years of data. But for the first time in a long time, we actually did see a decline in the number of folks who are using prescription opioids. So looking at the United States, and this is the area obviously we're all interested in. We've got Kentucky, Ohio, and West Virginia. And we see that they're in the second tier as far as the number of folks who are using prescription pain relievers non-medically. And unfortunately, the terminology is all over the place. We've got non-medical pain reliever use, abuse, non-medical use. It's kind of crazy, but basically what we're talking about is folks who are using opioids not for the reasons they were intended, or taking more than for what was prescribed, or taking to get high, so for the euphoric effects. And we see that these folks are in that second tier. For a long time, Kentucky was in that top tier, and that's actually gone down, which is a good thing. But at the same time, I think we're still facing a major epidemic in Appalachian Kentucky in particular. So something nice that the National Survey has done lately, as you know, they won't release state-level data for you and I to do analyses. Data are available for you to do your own analyses, but they don't release the state-level data because they think that you'll actually be able to identify the participants. I say that's hooey, but when you've got 70,000 folks, I really don't think having state-level data, I'd be able to figure out exactly who was the respondent. But I appreciate that they're trying to protect the anonymity of their research subjects. So folks who actually participated in the survey, they've actually now given us these sub-state analyses, which do a little bit better at getting down. And we see that folks in some of these areas that we're interested in, Appalachia, you see a little bit higher rates than the state as a whole. But then when you look at any substance use disorders, we're back down to middle of the road. So I personally think that, and I think the data do support this, that a lot of the substance use disorders in this area are being driven largely by the abuse of prescription opioids and pain relievers. Not shockingly, when we actually look at serious mental illness, we see very high rates of serious mental illness in this area in the black circle as well. So Appalachian, Kentucky, Ohio, and West Virginia. And as we all know, there's great comorbidity between substance use and mental disorders, so it's not surprising that we're seeing the numbers of those folks with serious mental illness being great as well. In the National Survey on Drug Use and Health, when they talk about non-medical use, you could have used a prescription opioid one time for not the intent, and you're counted as being a user. Whereas when you're looking at abuse and dependence, you have to meet certain criteria. So these are the folks who are truly abusing the drug or are dependent on prescription pain relievers. And we see that the number of folks who meet this more stringent abuse and dependence criteria is actually second only to marijuana. And for this being such a new epidemic, I think this is very curious. And then when you go and compare 2001 to 2011, with 2001 being in the blue and 2011 being in the red, you see that all the drugs, apart from pain relievers and heroin, so the two opiates, have actually gone down in terms of the number of folks who meet abuse or dependence criteria, but the pain relievers and heroin is actually going up. This is an older slide, but I think it really tells a story because this is actually treatment admissions for, again, the terminology, narcotic painkillers, again, prescription opioids. This is from the treatment episode data set, so TEDS, when they were looking at the percent increase in treatment admissions for prescription pain relievers. And we see that the largest increase, 269% increase in the most rural areas of the United States compared to only a 58% increase in the most urban areas of the United States. And I think that really kind of tells the story of what's going on in Appalachia. So Dr. Denham presented this map. Her data is a lot newer than mine. Hers is 2013. Clearly, I need to update. But I present this all the time. A lot of times when I present internationally, people have no idea about Appalachia. This is a really good way to present the geography to them. You all are well aware of the geography of Appalachia. And then Dr. Denham also presented the data on the economic well-being, which I think we can all say is poor for this area. These are amongst the poorest counties in the United States. And I think that provides, again, some additional context as to potentially the reasons why we're seeing the acuity of the prescription drug abuse epidemic in Appalachia. So I'm often asked about the differing trends. Why are the drug abuse trends so different specifically in Appalachia, but in Appalachia versus urban areas? And I think a lot of it has to do with availability. Availability of drugs such as heroin, which is commonly abused in urban areas, we just don't see it, at least in the area of Appalachia I'm in. We had some folks present data earlier indicating that there actually are some increases in heroin use in Appalachian areas. But they talked specifically about Portsmouth. Well, Portsmouth is actually at the intersection of several interstates, whereas the area we're in Appalachia, we're a good 2.5 hours from an interstate. So the availability of heroin is a lot different, I think, in our area of Appalachia. Now, we monitor that consistently because we're hearing anecdotal reports from all over Appalachia that there have been increases in heroin, but we're just not seeing it. What you do have in a lot of these rural towns is a drugstore. And you can also potentially get all of the ingredients to manufacture methamphetamine. We don't see a lot of methamphetamine abuse in Appalachian Kentucky at least, but we do see a whole lot of prescription opioid abuse. And early in the epidemic, it started just like everyone describes. You have some people who are in laborious industries, such as coal mining. They are prescribed prescription opioids, and they share the wealth with their family, their friends. That has since changed. We really don't see kind of that mom and pop giving it out to their friends and family anymore. What we're seeing are very sophisticated distribution networks, oftentimes groups of folks going to Florida. This is probably not happening as much now with the prescription monitoring system in Florida, but up until very recently, big groups of folks going down to the pain clinics in Florida and bringing back large numbers of pills, thousands and thousands of pills in any one given trip. So it's no longer, again, sharing amongst friends and family. There are different levels of dealers in the county that we're in particular. So I think the differing trends have a lot to do with availability, and that's why we see a lot more prescription opioid abuse, at least in these areas that we're in. So I think up until very recently, and I think that you folks that do research in Appalachia will support the fact that there are few empirical reports about prescription drug abuse in rural areas, and even less about HIV and other medical consequences of injection drug use, which up until recently we thought was very rare in Appalachia. Carl Lukefeld and colleagues were interested in doing a study on looking at the potential for HIV in the late 90s, and they found very few folks were actually injecting drugs. We went back in around 2004 and found that 40% of the folks that we found alone were injecting drugs. And they're not injecting, it won't go back. They're not injecting drugs that we normally think of when we think of urban drug use. They're not injecting heroin, they're not injecting cocaine. Most initiated with OxyContin, and other prescription opioids. So this is something very new and very different. Well, along with injection drug use, you often get HIV and hepatitis. So that's what we were seeing with regard to self-reports, but we wanted to know what was going on truly in the community and go out and test a bunch of folks. So the impetus for this research was We didn't know a lot about the longitudinal nature of prescription drug abuse. It's a very new epidemic. There have been tons of studies done looking at the longitudinal course of heroin abuse, cocaine abuse, marijuana abuse. Very little known about prescription drug abuse. Injection drug use is new in Appalachia. What's going on with these folks? How do they differ in their risk patterns with regard to injection drug use versus urban areas? Or is it exactly the same? We didn't know. We didn't know anything about the infectious disease prevalence and incidence. Again, we were relying on self-report. And some of these more important topics that I was happy that Dr. Denham brought up this morning, social networks, the importance of networks, especially in rural areas where you have very tight-knit communities. What is the impact potentially of social network formation in these groups? And then also you're talking about some potential geographic isolation. So how does that play into drug abuse and long-term drug abuse patterns? So we got ourselves in gear and we wrote a grant to NIDA and we're lucky enough to get funded. And in 2008, we started the Social Networks Among Appalachian People, or SNAP study, the purpose of which was to determine the prevalence and incidence of hepatitis C, HIV, herpes simplex 2 virus, and other risk behaviors in relation to their network formation, so their social network characteristics, and prescription drug use. And we followed them at 6, 12, and 18 months, and now we've actually initiated a 24-month follow-up as well because we think it's very important to keep on these people to, again, kind of determine what's going on longitudinally in this cohort. So we recruited 500 out of treatment. They were out of treatment at baseline. They could have entered treatment at any point during the course of the study. Both injection and non-injection drug users, and again, we're following them in 6-month increments, which corresponds to the seroconversion window for HIV. We have a storefront location in a rural town, and we recruited our participants via respondent-driven sampling. For those of you who are not familiar with RDS, it's a form of snowball sampling where you go out and recruit your peers. It's most often utilized when you have hidden populations. So we're going into a community where we know very few folks, and we're asking them to divulge all of their secrets to us for all intents and purposes. And in order to bring people into the study, we had to rely on their peers to bring them to us. So what we do is we initially identified seeds, and we just posted little flyers in our community. And of course, when you go into the community, you have to get community support. So we went and talked to the stakeholders, and they were more than happy to identify folks that they thought would potentially be appropriate for the study. Once we had our seeds, we asked them to bring us 3 of their peers, and they did so through 14 waves of recruitment to get 500 folks. So, this is a really busy slide on our follow-up rates, but the take-home message is when you're doing community-based research, especially in a community, I am not from Appalachia, I'm from New England, so for me to go in and try to do a study where I didn't employ local folks who are familiar with the different potential cultural nuances, who actually wanted to listen to them. These are folks that are oftentimes very far along in their drug injection career or their drug using careers, and they just want someone to talk to, so someone who would be patient with them, who would talk to them. It was so important for us to establish rapport because we're asking them to come to us every 6 months to do testing, to, again, divulge a lot of very personal information. So you had to get really good folks on the ground, and I think we were very successful in doing that because we have overall 95% follow-up rates at 18 months, which I think is potentially unheard of in this type of research. So all the credit is to the local interviewers and the local staff in Hazard. And we see that, the lowest rate we ever had was just below 80%, but for the most part, we are well above 90-95% throughout the course of the study. So this is a super busy slide, but the take-home message is, so you see this black line at the bottom. We had fairly steady recruitment over the course of the study. And we had some really interesting seasonal patterns. So as Dr. Denham talked about earlier, a lot of this area is exceedingly mountainous, and when you get into the winter months, it's hard to get around. So what we saw was in the winter months, the folks were coming from very close to the study site, so 2 kilometers or less away. When you get into the summer months, people were coming up to 30, 40 kilometers away to participate in the study. So really interesting kind of recruitment patterns with regard to seasonality. This is actually our storefront location. It's in Hazard, Kentucky, and the irony of the name of the town is not lost, I must say. And you see that we have very little signage, and that's to protect the anonymity of our subjects. It's very important to us that they be able to come in and out kind of undetected, but it's a small town. Everyone knows what's going on there. But at the same time, it has a back entrance. If they feel more comfortable coming in out of the back entrance, we allow them to do that. And again, we don't have big signs that say Center on Drug and Alcohol Research. That's for the safety of the people that work there, because people would assume if you say Center on Drug and Alcohol Research that we actually have drugs and alcohol there, which we don't. And also, again, to protect the anonymity of our research subjects. So to be in the SNAP study, they had to be at least 18 English speaking, and all of our initial seeds that we used to go out and recruit their peers were all injection drug users. And again, we're very interested in kind of those risk behaviors and those medical consequences. So at least the first few folks, we wanted to be injectors in hopes that they would bring us other injectors. That wasn't the eligibility criteria. We just asked them to go out and sample their peers, their drug-using peers, in the hopes that we would get both injectors and non-injectors, which we did. They had to have used at least one of the following drugs in the prior 6 months. So the prescription opiates, cocaine, heroin, methamphetamine. Certainly we had a smattering of folks using cocaine, heroin, and methamphetamine. Every single person that walked in the door had a history of prescription drug abuse, whether it be opioids or benzodiazepines. So long-term, what kind of outcomes are we looking at? We both wanted to measure the prevalence of HIV, Hep C, herpes simplex 2, but we also wanted to look at incident cases. So at every single visit, we're testing them for HIV, Hep C, and herpes simplex 2 virus. We're also not only interested in HIV itself, but the risk behaviors involved, because some of those risky sexual and injection practices don't just put them at risk for HIV, but other infectious complications as well. Very interested in overdose, and we're also very interested in the potential access to treatment for these folks. So again, I can't say enough about the interviewers we have. They are spectacular. They not only interview the folks, but they also track them. So sometimes it's not interviewing them at that nice little storefront location. They got to go to prison and jail, and they have to drive all the way 6 hours to Western Kentucky to get them in the Western Kentucky Correctional Complex. And they do it without complaint. And they've really been kind of the backbone of this study. So we do interviewer-administered versus ACASI or other kind of self-administered surveys, because a lot of these folks, the illiteracy rate is rather high, and a lot of them don't have the exposure to technology that you do potentially in urban areas. And again, for us, it's so important to establish that rapport, and by having the interviewer-administered questionnaire, we were really able to do that. So we do the serologic testing with pre- and post-test counseling. All of our interviewers are certified HIV counselors. And basically what they do is before they administer the test, they tell them all the potential discomforts. We do a finger prick for one of the tests, and just kind of give them an idea, put them at ease, tell them what's going to happen. And then we have all rapid tests so we can give them the results on the spot, which is very important. And then we tailor their post-test counseling to whatever result they get. So often what we'll see is HIV negative, HCV positive, HSV2 positive. And we give them advice on first how to, again, continue to protect themselves from HIV, since they are HIV negative at the time. But then we counsel them on the ways in which they can prevent transmitting HCV and HSV2 to their injection partners and sex partners. So a little more than half of the sample are male. Median age is about 31 years of age. Only about a third are in have full-time employment. By design, about 80% have a history of injection drug use. I can say that we've done over 2,000 rapid HIV tests, and we still have not had one positive test, which is obviously exceedingly encouraging, but very curious at the same time, because we know they're engaging in a lot of the risk behaviors for HIV. We can't say the same thing for Hep C. The baseline prevalence rate was 44%, and with all of the incident cases, we're now up at about 60% seroprevalence rate. And if you've read any of the studies by Peter Vickerman at the London School, he's really interested in modeling potential for HIV. And he said if you have anything above 55% prevalence rate for HCV, you should see cases of HIV in the community. And we're just not seeing it yet. We also had kind of curious rates for HSV2. As you're well aware, the national average is about 20%, so we were actually encouraged to see prevalence rates below 20%. But then over the course of the study, when you add your prevalent incident cases, we're now at above or slightly above the national average. So this is the slide that, especially when I present to folks who are not familiar with prescription drug abuse, that really kind of gets people, because if we were in an urban area, we'd see lots of heroin abuse, cocaine, maybe a little bit of methamphetamine. But what we're seeing in our cohort is people are using methadone. Again, this is the methadone that is prescribed for pain, not the methadone that you're getting in the clinic. I don't want to give a methadone from the clinic's bad rep. Oxycontin, oxycodone, hydrocodone, and benzodiazepines. So this is predominantly a prescription drug abusing population. We see very little methamphetamine use and very little heroin abuse. And we do see a few folks who are using cocaine. A lot of times they'll use it in conjunction with their prescription pain relievers. I want to talk a little bit about benzodiazepines. Now, Mr. Botticelli brought this up earlier, and I don't think we pay enough attention to benzodiazepine abuse, and we're really seeing a whole lot of benzodiazepine abuse, especially in this cohort. More than 90% of the folks indicate lifetime use of Xanax or alprazolam. And we see over 60% are using Klonopin, just over 60% using Valium. And they're not just using one, they're using a bunch together. And they're mixing it with their prescription opioids, which again is going to put them at risk for overdose. So again, when you look in the empirical literature, you don't see anything about prescription benzodiazepine abuse. It's just recently being recognized as being a problem. And we had a very enterprising PharmD MPH candidate just recently come through who's really interested in this. And I brought this directly over from his capstone project, so the colors aren't necessarily great, but the take-home message is people just aren't using Xanax alone. They're using Xanax and Klonopin, Xanax and Valium, Valium and Klonopin, or all three of them together, in addition to the opioids. So they really are putting themselves at great risk for overdose. So I think that this represents the overall cohort. And I think it was interesting when I presented this in the past. I think a lot of people were really interested, not in this first box, because any study you do in any area, you're probably going to see these being the first two drugs that people are using. But then you move from alcohol and marijuana to benzodiazepines and hydrocodone. That is different from what goes on in a lot of areas, especially in urban areas. Then you're getting into the oxycodone and crack. But then I was thinking about this the other day, and I said, you know, I don't think this pattern would hold true for the younger folks. So I split it out and looked at kind of the trajectory of drug use for those under 30 years of age in our cohort and those who came into the study who are over 30 years of age, and it's completely different. And I think that Mr. Botticelli did actually touch on this earlier. We're seeing completely different trajectories for young folks versus older folks. So we're seeing that they're not starting with alcohol, but marijuana, then moving to alcohol. And then while they're still school age, you remember the previous slide, they weren't using benzos and hydrocodone until they were 18, 20 years of age. While they're still school age, they're exposed to benzos and hydrocodone, oxycodone while they're still school age. And then when they're entering that time where they're moving on potentially from high school, they're already into Oxycontin, crack, cocaine, and starting to inject in late adolescence, early adulthood. Whereas the folks who were greater than 30 years of age, they weren't even getting into the prescription drugs until they were age 20 or so. So we're seeing completely different drug abuse patterns for younger folks versus older folks, and very early exposure to the prescription drugs. So I'm often asked what's happening with regard to the new formulation of OxyContin. As you all know, OxyContin was reformulated in 2010. They're not technically allowed to say it's abuse deterrent, but that's the idea. They've made it such that it's difficult to get around to be able to use via alternative routes of administration. So they made it a lot harder for you to crush it up, snort it, or inject it. And I think for the most part, they've succeeded in doing so. We have talked to most of our folks, and they say it's very difficult, too time-consuming to get around, and if they can get it down to to at least not the solid formulation, it is a goo. They can't shoot it up, and they certainly can't shoot it. I mean, they can't shoot it up, and they certainly can't snort it. And if they try to even hit it with a sledgehammer, it only goes into chunks that wouldn't be amenable to being injected or snorted. So in that respect, it's working. OxyContin was by far the drug of choice in this population up until very recently, but we were already starting to see declines. It's very expensive, and I think you all know that when folks get very far down into their drug-using career, the funds tend to dry up quite a bit. So they were already starting to look at alternatives to OxyContin, and what they were starting to use very early on, and it's starting to go up, and I think what we'll eventually see is that up to the levels that we saw for OxyContin is immediate release oxycodone or roxicodone. That's what we're seeing. We're not seeing that because an abuse deterrent formulation came on the market that people stopped using. No, what they did was they ended up substituting with another drug, and what they're substituting with is roxicodone. On the street, they call them IR30s. They can crush them to snort and inject just like they were doing for OxyContin, and they're far cheaper. So what are they injecting with? Well, first, I think, again, we're very interested in what they initiated injection with. And again, what we're seeing are that most folks, more than half of the folks, initiated with a prescription opiate versus heroin, which we often see in urban areas. And the folks that did initiate with cocaine are the older folks in our cohort. So they had initiated back in the late 70s and early 80s. So for the most part, the folks that are initiating more recently are doing so with prescription drugs. And then we ask them, well, out of all the drugs you've injected in your lifetime, not just the first time you injected, what are you using? Again, predominantly they're injecting prescription opiates on a regular basis, followed by cocaine. But again, this is lifetime injections, so you have a lot of folks who had injected cocaine back in the 70s and 80s. But we do see folks that are mixing cocaine and prescription opiates, and they call it the hillbilly speedball, because the speedball in urban areas is going to be heroin and cocaine. In our area, we're looking at, it used to be OxyContin and cocaine, but now they're injecting the immediate release oxycodone and cocaine in combination. So we're, again, very interested in people who initiate injection over the course of the study, because hopefully we can identify the risk factors and develop an appropriate intervention. So we see that we don't see a sharp increase. We're only adding 10, 11, 12 injectors at each of the follow-up visits, but we started with almost 80% with a lifetime history of injection. So now we're up at almost 90% of folks who are injecting. And you'll see here that the red part of the bar represents the proportion who are Hep C positive, and you're seeing more than half the folks who are injecting are indeed Hep C positive. Again, we're really interested in kind of that initiation of injection, hoping to identify risk factors that we can potentially intervene on to prevent initiation of injection. If you can prevent initiation of injection, you can prevent a whole host of issues, most of the infectious diseases that we've talked about already, HIV, Hep C, Hep B. We see here, again, that this is significant. This is the FDA approval of OxyContin. As you saw in previous slides, that is the drug that most folks were initiating with. So after the FDA approval, you saw a huge spike in the number of folks who began injecting. So again, most of these folks had injected cocaine back in the 70s and 80s. So these are the folks we're really interested in, because they're the current injectors, and they're the folks that we can hopefully look at their characteristics to identify points of intervention. So this slide's a little bit difficult to read, but the take-home message is when you look at time from first using a drug to initiation of injection, it is by far the fastest for those using OxyContin. So for the time they first use the drug to the first time they inject, for over half of them, it was less than 5 years, whereas in heroin and cocaine users, you usually see a much longer trajectory to where they get to injection. So take-home message here is prescription opioid users are initiating much faster than we would see in urban injection, cocaine, and heroin users. So again, one thing I'm very happy that Dr. Denham talked about this morning was the importance of social networks. So, and it's something that really hasn't been explored in rural areas, and I don't understand why, because if you think about rural areas and what we know about Appalachia is that really tight knit community, that kinship, if you will. And there's also great potential to do really good things with social networks. It doesn't just facilitate, in this case, disease transmission, but you have the potential in these really tight-knit networks to also disseminate information, interventions, prevention. So I think it was really important for us to characterize the networks in rural areas, both from the perspective of infectious disease transmission, as well as for the potential to disseminate positive messages and positive information. So what we do is we ask folks in the interview to name the first name and last initial of all the people they've used drugs with, had sex with, and count on for social support in the prior 6-month period. Obviously, we're asking very personal information. It's amazing. We can actually look. The first few folks we interviewed name 3, 4, 5 people, and then once we were in the community for a while, we'd established that trust, that rapport with the community. Now they're naming 24 people in their network. So I think, again, it was very important for our interviewers to establish that level of trust, and for us as the investigators to establish the fact that we hold all of our information very tightly and that everything is treated with the utmost respect and confidentiality. So not surprising, since we're asking folks to go out and bring us their drug-using peers, the greatest number of folks in the network were in the drug network. They, unfortunately, the folks that they count on for social support, a median of 2, there's a lot of overlap between the folks in their drug network and the folks in their support network. That's what we call multiplex relationships in social network analysis. And what that means is it's not truly someone you can count on for support if you're also shooting up with them. When we think about social support, we think about people who are potentially outside of that immediate your immediate kind of peer group that you can truly count on to give you an outsider's perspective. And they really, unfortunately, don't have that in this particular cohort. So this is the drug network, and no, this is not what you would expect. It would potentially be what you would expect in Appalachia, given that what we know about, again, close-knit community, close-knit networks, but at the same time, if you look at the literature, the studies that are done by Rich Rothenberg in Atlanta, or in Colorado Springs, and he's actually done some work in Atlanta as well. If you look at the studies by Sam Friedman in New York and Carl Latkin in Baltimore, they're not seeing this. This is what we call a component, and this is one huge component. What you would expect to see is maybe 20, 30 people grouped together. We have 407 people grouped together out of 500. So you can see great potential for disease transmission in this network, but on a positive note, you also see great potential for information, the travel of information, potentially positive information. And I've got a great story about that. So there's a guy somewhere right in this area who we tell them in their post-test counseling, if they come back Hep C positive, we say, or even negative, we say, there's potential for the spread of Hep C via sharing straws. And a lot of people don't know that. There was a study that came out in the past, probably 5 years or so, that showed biologic plausibility of Hep C transmission via nasal passages. So we tell him this, and he gets all excited about it. He maybe procured some straws illegally from McDonald's, but he grabbed a bunch of straws, he cut them up, and he started passing them out to his friends. And he said, no, we shouldn't be sharing straws. So, there's a nice, just amazing message that is spread. And he had a lot of reach in the network. So he's not just connected to one person, he's connected to 30 or 40 different people. So for one person to have that, be able to kind of deliver that positive message, so we obviously see a lot of potential for negative consequences in this network, but there's also potential for positive messages as well. So obviously, if you're all using your own syringes that you removed from the package and you're disposing of immediately after, you don't have to worry about any of these infectious diseases. But we know drug users, and we know that they don't necessarily practice what they preach. They may say, I never use a syringe that somebody else has used. And then they get high and they're in the middle of it, and the only syringe they have access to is the one that their buddy just used, and they end up using it. So we have about a third of the folks that are regularly injecting who indicate they share syringes. We have a whole host that are sharing all the implements used to prepare the drugs for injection. I think a lot of those folks are unaware that Hep C is highly transmissible and has been found on all of these different implements. The more you inject, the more you put yourselves at risk. We have a little more than a third of folks who are injecting daily. Everyone's sharing straws. Now, this is at the 6-month time point. But I think if we look over time, even though we had that one guy who was so intent on everybody not sharing straws, we still see at 24 months, we're still seeing a lot of folks who are indeed sharing straws. And then I'm going to talk a little bit about overdose in a minute, but about a third of the folks had experienced a non-fatal overdose. So for me, I'm an infectious disease epidemiologist, so this was actually shocking. Again, some of the early work we did, the self-reported cases, 15% in injectors versus 1% in non-injectors, I said, oh, there might actually be some hep C here. We weren't expecting rates up now around 60%. As you all know, hep C is exceedingly expensive to treat. A lot of these folks don't have access to treatment, and the potential liver complications down the line are going to cost us billions and billions of dollars. So this is kind of what we call probably something that's waiting to explode over time. And unfortunately, the folks that when we deliver the message, hey, you've tested positive for hep C, they just don't care. They don't care that they have potentially a long-term chronic disease that could kill them over time. But you tell them they have herpes and they freak out. So it's just, and that's something they can manage over time, and it's not going to kill them. So it's just, I think that there's a lack of education especially amongst these relatively, this is a new phenomenon. People haven't been injectors in the past. So they really are lacking in education. And some of the messages we give them in the post-test counseling, they're just shocked to learn this information. So I think this area certainly, and probably other areas that you all are in, are ripe for some type of even just minimally, some education around safe injection practices. So again, at baseline, we saw about 44%, which shocked the heck out of us. But then over time, we've seen another 82 cases, and this really, there was a little longer between, there was a little less, there was more than 6 months between the 18 and the 24-month follow-up. So we expected to see quite a few cases. We didn't expect to see another additional 45 cases. So we are still seeing cases. I was actually hoping that this had died down while we were out of the field for a good 6 to 8 months, and that was unfortunately not the case. So again, this is bringing us back to our drug network. This is the baseline HCV number. So the red dots represent HCV positive and the blue dots are negative. Now we're going to look at it over time. Now we see the yellow dots are the incident cases, and you'll note that most have a direct connection to a red dot, which was a baseline case. Except right here, you see this is a good example of where they don't have a direct connection. But in order to, this is what we call our sociometric network. We have to verify the identity of every single person to be included in this sociometric network. So what may have happened here is this person may have had a connection to someone who is HCV positive, but we're not able to verify their identity to include them in this network. So more than likely, they obviously had exposure to somebody who is HCV positive. We're just unfortunately not able to capture that in the network. But I think if we, again, point up here, well, this person was injecting with this person, and now they're positive. And then when we look at 18 months, that whole triad up there are now all positive. And we see that throughout the network. Direct connections to people who are HCV positive at baseline or one of the follow-ups, then they become HCV positive at the next subsequent follow-up visit. And at the 24-month network, again, we saw an additional 45 cases. And now you're seeing a whole lot of yellow dots mixed in with the red dots. And there are still certainly some hep C negative folks, but these are the folks either that are not injecting or no longer injecting, or we do have a few folks who indicate they do. Every single time they inject, they're using their own syringe that they take out of the package. One of the bonuses, if you will, of having a lot of diabetes cases in this area is that there's a lot of access to clean syringes potentially. So I guess if there's one silver lining about all the diabetes is that we have a whole lot of syringes available for folks to hopefully use and then dispose of. So we're in the midst of analyzing the incident cases, but when we looked at the prevalence cases, nothing should be surprising here. Those who are sharing syringes are more likely to be hep C positive at baseline. For every additional year that they've been injecting, the odds of being hep C positive is 4% greater. And this, I think, is a matter of younger injectors versus older injectors. So those who are younger, who came up Hep C positive, had a history of injecting prescription drugs. Those who are older, who probably had cases that date back 20, 30 years, they were injecting cocaine. So we have not been immune to overdoses in this cohort. We've had a little more, I think 21 deaths at this point, and 5 are confirmed overdoses. We do collect the death certificates on all of the folks that we know are deceased. And from the 5 confirmed fatal overdoses, 3 had both opioids and benzodiazepines in the system. Again, not surprising. That's what we see in a lot of the decedent literature. We had 1 unknown, and that's because they overdosed in their community and then were flown to Lexington for follow-up, and they didn't code the death as an overdose because they weren't presenting at the hospital in Lexington with an overdose. So we don't know what was in the system, but it was confirmed by family members that that was indeed an overdose. About a third of the folks, a little less than a third, indicated at baseline that they had experienced a non-fatal overdose at least once in their lifetime. Amongst those who have an overdose, the median number of overdoses is 2. So more than half of the folks had 2 or more overdoses in their lifetime. We haven't had what I would say an alarming number of non-fatal overdoses, but it's not inconsequential either. We have had 34 overdoses and, again, 5 overdose deaths. So we are definitely seeing overdoses in the population. And again, most indicate on the day that they overdosed, they were using both opiates and benzodiazepines. So again, we're in the midst of analyzing the longitudinal data, but when we looked at the baseline data of the folks who had 1 or more non-fatal overdoses, we found that having been in drug treatment, as we all know, that's a major risk factor for overdose. Injecting prescription opiates, which keeps coming up time and time again as a risk factor for all these different kind of negative consequences. And a history of post-traumatic stress disorder and antisocial personality disorder. ASPD, again, comes up all the time when you're talking about comorbidities. And then, interestingly, when we looked at, so we analyzed the individual factors, and then we looked at the social network variables as well, and we didn't include them in the same model because you kind of have some issues with nesting. So we looked at them in a different model, and we found that having additional support network members was actually put them as having greater odds of an overdose. And we thought that was really curious. But then when you think back to the multiplex relationships, most of the folks that they count on for social support are also in their drug-using network. So they aren't truly supportive folks. To me, what this indicates is they have a large drug network, that they kind of count on some of those people for support, and they were more likely to be in a big group of people who were putting themselves at risk for overdose. Lastly, I'd like to touch on treatment and the lack of treatment in rural Appalachia. I think it's definitely been touched on already today that the access of these folks to treatment, it's very poor. And what we see is a little more than half indicate they had some exposure to substance abuse treatment in the past. A lot of times it's court-ordered, it's local, it's not based on evidence-based practices, best practices in substance abuse treatment. And then we see very low rates of engagement over time. So we had just a little over 10% of the folks enter treatment between the baseline and 6, between the 6 and the 12, and the 12 and 18. And when they are entering treatment, most of the time it's AANA, that's what's local. It's not necessarily the most efficacious form of treatment for folks who are very far along in their opiate dependence. What we're seeing very little of is methadone and buprenorphine. I will say in the community we're in, there is a methadone clinic. It's private, for-profit, so most of our folks, even if they wanted to get in, can't afford it. The couple of buprenorphine providers we do have are for-profit, and they came to the community as a result of their knowledge that there's a prescription opioid problem. And so these are not folks who are primary care providers in the community who care about providing treatment. They're actually kind of enterprising folks who came to the community and started a buprenorphine clinic for the sole purpose of profit. So unfortunately, really in this community that we're in, we have very little access to medication-assisted treatment, which we all know has been shown to be exceedingly efficacious for opioid dependence. So I'm hoping some of the results of this study will have given us a clearer picture. Again, ongoing study. We're really interested in following these folks for as long as possible to give us a better idea of the longitudinal nature of prescription opioid abuse and prescription drug abuse in rural Appalachia. The prevalence rates in the urban areas are approaching that of the rural areas, but at the same time, I feel like we see the issues much more acutely in rural areas. So we may see that 10% of adolescents in urban areas are using prescription opioids and 10% in rural areas, but it seems so much more of an acute problem in rural areas compared to the urban areas. Again, high prevalence of Hep C, and I'm just not sure where we're going to go with that. Obviously, there needs to be some type of intervention, whether it be hooking these people up with treatment. Obviously, there's a huge potential prevention message in the communities that we're in. I don't think we're alone in seeing these high Hep C rates. We hear a lot of anecdotal evidence from local physicians in the varying counties in Appalachia that are seeing very similar rates of HCV. I think a huge issue is the concomitant use of opioids and benzodiazepines, which is leading to overdose. So what does that mean for us? I think I just went to a great talk about overdose prevention in naloxone. I think we're not alone in wanting to get a naloxone intervention out into the community. We think it's absolutely necessary. It's just, again, finding funding to do so. And I feel like some of the federal agencies are finally coming around to funding some of these overdose prevention. And I think that our area is, and many of the areas in Appalachia are ripe for this type of intervention. A question for me, again, as an infectious disease person, why is there no HIV? Now, someone would say, don't look a gift horse in the mouth, but what I say to that is there are potentially some underlying reasons that could be very important. We need to know what the level of intervention or prevention needs to be in these communities that are very resource deprived. Do we need to scale up or scale down, or what groups should we be hitting with regard to the HIV message? Because I think it's just a matter of time until HIV does reach these communities. So we're looking at potential genetic factors. There are some mutations that have been shown to be protective against HIV. We're also interested in kind of the geospatial. So, we talk about Appalachia as kind of a geographically isolated area, but is it also socially isolated? Are they leaving the area and going and having sex in high-risk areas and high seroprevalence areas? So I think we need to know that before we can make a decision about what type of intervention we need to have in the area. And then again, looking even more closely at the longitudinal nature of the networks. So what I was showing you were the baseline networks, but what happens to the networks over time? Do they degrade, or are they actually, which would potentially be protective, or are, on the opposite end, are they actually going to be more risky over time? So those are the things we're interested in looking at long term, and we hope to continue this cohort and continue to replenish this cohort. So these are the things we can be studying over time. And finally, Hep C treatment. Again, I'm not sure how we're going to address this. I'm an epidemiologist, and so I'm kind of now trying to navigate working with folks who can actually potentially put this type of intervention into effect. So hooking them up with someone who can treat their Hep C, even just to the point of getting them tested, doing further testing and treatment, determine what the best potential course of treatment is, if at all. So they're not even able to kind of hook up with local providers to get any sort of treatment for their Hep C. Never mind any higher level treatment. So I need to thank NIDA, who have been very kind in funding this study, and now we are also looking at more closely the potential changes in drug use patterns as a result of the change in the OxyContin formulation. So that's the second RO1 that we received. And then these are the folks that have been involved in the study. And finally, I really do need to thank our participants who, again, have been sharing just very personal information with us over time and have stayed engaged in the research, again, which was very encouraging to us. potentially to do other types of research as well, not just drug abuse research. So we were able to get in and get these folks to engage in treatment. And again, that's all due to the amazing study staff we have in Hazard, and also the folks in Lexington who are analyzing the 2 to 3 million data points that we have at this point. So everyone's doing a tremendous job, and I wouldn't be here certainly without the staff and the participants. So thank you so much.